Whitney has been around and presenting information on education. I think primarily I met you at a massage and myotherapy, so AAMT conference, handful of years ago, where you were doing orthopedic assessment.
Yeah.
And I've got your textbooks back there in my my small minimalized library. We end up with 1 million books, and then we bring them down to the ones that we really think are valuable. And I have to say that yours is still part of the value set in the orthopedic assessments.
Well, thank you very much. It's good to know. I had a school owner once tell me that my book was the most stolen book in their library. Okay, maybe that's a compliment. I read that.
Yeah, unless it's stolen by other orthopedic practitioners who write stuff. Whitney, I've known you for, as I said, a long time. How long have you been in the industry, and can you give us your elevator pitch?
Yeah, certainly. Been in the massage world since 1988. So I give you the numbers. I think it's like 33 years now or something like that. So it's getting on up there. It's one of those things you stop counting after a certain while and you don't want to count them anymore. But my predominant focus during that time has been treating pain and injury problems, and especially focusing on orthopedic assessment. But I'm also very passionately focused on education in a variety of different realms, both in the continuing education world and some in entry-level training, but really looking at how to produce high-quality educational programs for massage therapists, because there's a lot of people out there who just know a lot of really great stuff. And unfortunately, what often happens is that those people, if they don't recognize or learn how to teach well, those things don't come across really effectively either. So I put a lot of emphasis into trying to learn how to become a much better teacher, as well as the other things that I'm doing with clinical applications in orthopedic world.
You're right there. Some of the most amazing teachers are actually terrible teachers online. They're like, they can really impart information in a face-to-face venue, but this is a whole new world now, isn't it?
It absolutely is. And it's, that's what you just mentioned there a moment ago too, is so critically important, that it is a completely different skill set to teach well online. I started working on online education actually in the late 90s. So it's been a long time that I've been studying this stuff and trying to learn how to do it effectively and do it well. And I just can't imagine the stress and the challenge that so many of these people were thrown into, having to figure out, like, overnight, how to turn their whole educational programs into an online course. And, this whole emergency remote teaching thing is very different than a really good quality online course, but it's a very different skill set altogether.
Yeah, I know. And I've been modifying everything down to teaching, 3-hour blocks, as a lot of people have been doing 3-hour webinars, 3-hour stints. I was lucky enough to run a weekend program, like a face-to-face, where you actually in the same room with a group of therapists for 9 to 5 for 2 days. And I was completely whacked because the energy levels, that sustained energy level, we haven't done for over a year.
Yeah.
Like close to 2.
Right. And you were already doing some online stuff before the pandemic, weren't you? Weren't you doing some courses and stuff online? Yeah.
I've been doing online self-paced, and then I've just moved it to online virtual live streaming. So the entire face-to-face course gets broken down into 5 3-hour webinars, but even that. So I'm in here in my clinic, and I've got videos of the actual techniques that we're going to go through, and in a perfect world, they're in their clinical space with somebody. So it's still, you're treating one-on-one, and those people who don't have someone who they can work with are still going to be going through and doing either the pre-assessment orthopedic, like how do you feel with standing, sitting, doing the technique, self-technique, and then subjectively working through it. So here we come to the first part of this whole pain perception and how the body works. It's all interoception then.
Yeah.
Because you're having to come deep into yourself and go, well, did that make a difference or did it not?
Right. Yeah. And that's posed some really interesting and challenging things for us to try to do some of that kind of stuff in that environment. But I have also seen some really innovative things that people have come up with doing during this time too. So, it's been inspiring to see some of the ideas that people have come together with for how to do this.
Yeah, it's amazing. So we haven't had anybody jumping on board yet, but I'm quite often people sit in the background and just listen. I have discovered over the time we quite like to be quiet little mice, and then at the end you get a flurry of questions. I was reading through last night. I saw in Massage Magazine, I think it was episode 35, that Jason Erickson had written an article, which was quite a good article on pain perception and the latest research. It made me think about it. I didn't realize that the biopsychosocial model first was coined up in 1977. I thought it was much older than, much more newer than that.
Yeah, actually it is. And this, I was actually in graduate school studying psychology before I got into massage. So this was in the 1980s, I think. Mid 1980s. We were learning about the biopsychosocial model in psychology graduate programs at that point. So yeah, it's been around a long time, but it's interesting. It did have kind of a resurgence recently in the last, couple decades or something like that. It sort of went underground for a while, not really got a lot of attention. So it appeared as if it was something new when it really was kind of a resurgence of some ideas that had been around for a while. And that, you see that kind of thing happen quite a good bit.
Yeah. Why do you think that people buried it? Was it too contentious?
I just think, it's one of those things that maybe we weren't really quite ready for it because we still had, at least in the world of, what our kind of slice of the world right now in sort of like the manual therapy world, there was still such a strong emphasis on some of the biomechanical and structural models. And we hadn't, think about this. This is also, 2.5 or 3 decades of additional research now that's been out since that first got started, that now really support the idea and give evidence of why this is a much more prevalent. And we've advanced a lot of neurophysiology and the capability of testing and evaluating a lot of these things that we didn't have back then. So, when it originally kind of started out as a theoretical model, we now have a base of research evidence to support a lot of these things. And that's why it certainly has gained a lot more momentum, I think.
Yeah. Interesting. He talks about those neurotags and how they compete for dominance. So that neuroplasticity, how, I didn't really realize we had a neurotag for action and a neurotag for modulation. So, in itself, the brain science it's being unpacked more and more so that the lay massage therapist can read it and go, well, one is going to be, if I could work on one area, which might be, exercise and movement, versus one that might be more going into how do you feel, how do you, more of the sensory.
Yeah. And,
change that treatment model.
A couple years ago, I was at a pain conference in San Diego, in California, here in the States. And this was a nation, well, it's sort of an international gathering of pain science researchers called the San Diego Pain Summit. And I was speaking to a physician who was there at that time. And we had, there's just all kinds of different professions that were represented there. Physicians, chiropractors, osteopaths, acupuncturists, mental health people, all kinds of professions represented there. And this physician, we were sitting around at lunch and he was saying to me, what's really interesting of all of these people here at this event and of all these different professions that are represented, I think massage therapy has the potential to have the greatest impact across the broadest spectrum of the biopsychosocial model. And I was thinking about that. I was like, I think there's a lot of truth in that. There's really so much that we can potentially do that cuts across many different facets of that spectrum of that model. It gives me a great deal of inspiration to think about, again, why massage has such a wonderful healing potential that it does have for so many people.
Yeah. So tell me about yours, because you've been primarily orthopedic assessment. How has this changed the way that you have been teaching and the way that you treat?
Yeah, well, it did, when I first got exposed to some of these ideas, pulled the metaphorical rug out from underneath me the way it did for many people, because I'm going to say grew up, and I'm talking about professionally in terms of my professional education. I grew up in a pretty structured orthopedic model, worked in orthopedic clinics for a number of years and worked with physiotherapy offices and places where we were putting a lot of emphasis on a really structural kind of model of the body, which is, you have a pain complaint in a certain area and you go do these certain types of tests and evaluation procedures, and you figure out the target tissue that's the problem, and then you do the thing to that target tissue that's going to fix it. So it's really kind of a model of being a mechanic almost, a structural mechanic, because that's really where the world of orthopedics emphasizes a tremendous amount. So the whole idea of looking at a lot of these concepts that came out of the biopsychosocial model of, when we first started talking about the big pieces, like the fact that people can have significant tissue damage and no pain, and significant pain and no tissue damage, really makes that whole model much more difficult to subscribe to as the thing to be doing to figure out what's wrong with everybody, because now we know there's a lot of times when it doesn't work, it doesn't apply. And so for me, it created this sort of crisis of conscience of what am I doing now? What is this supposed to be about? That was a really difficult transition period for me. It was, and a lot of people talk about this when they start learning about these things, about how it's, kind of like shattered or rocked their whole worldview, and it's changed the way that they've done all kinds of things. And as you know, one of the other difficulties is if you're somebody who's published a lot of stuff and put a lot of stuff out there, and now it's all wrong, that's another big one. And that causes a lot of people to not want to pay attention to this stuff and not listen to it because they want to adhere to their older models. So, that's not necessarily a really good thing either. But I went through this whole process, and I realized too that there was a degree of pendulum swing that I was latching onto, which was going really far in one direction. And I need to kind of come back to the middle ground and realize actually what this whole thing was doing, as far as I was seeing, was giving me a way to look at a lot of different things, but not de-emphasizing the value and importance of what I was doing with orthopedic assessment, but just actually broadening the horizons of how I look at the body and how things occur. So I would say that it left me feeling like I don't look at things with as much of a narrow view as I used to, that like, okay, I do this test and that hurts there. That means that particular tissue is damaged and I need to do something to fix it. But now we think of like, I do maybe a series of tests. I listen to what people talk about in their history. I put all these things together and say, is there a pattern emerging that would be consistent with something that looks to be a primary problem there? And if so, what might that be? And so instead of like now thinking about damaged tissue, I really think more about nociceptive drivers, meaning maybe this is the tissue that's driving the nociceptive sensations, and maybe it's damaged or maybe it's sensitized because of all kinds of other things that might be going on. And that's what I also have to peel apart and dig into and find out what's going on there. So it's really given a very different perspective on the whole assessment process in terms of how to figure out the nature of what a soft tissue pain complaint is about. And then, of course, that also changes and drives treatment decisions a great deal as well, too, because now we're learning a lot more about physiological effects of different treatment methods. And a lot of the stuff that I was taught, and probably you were taught too in massage school, about what we're doing to the tissue, like, we're doing deep friction and breaking up scar tissue and these, torn tendon fibers with tendonitis and all this kind of stuff, doesn't necessarily look like it's really happening in a lot of instances now. So what does that mean? What are we doing? So it's really opened up the opportunity for me to ask a lot more questions about what really is going on here and what are the things that are happening here. And I do think now, at least for me personally, a lot of these physiological reactions or results that we see from massage therapy are probably a lot more in the realm of neurological change than they are in the realm of structural tissue change. So I do think that still there are things that we can do to tissue. There are those people who will say you can't do anything to tissue, but if you've ever been hurt by something before, you know that you can have an external force that can do something to tissue. So I don't think we need to throw that baby out with the bathwater necessarily, but there's a lot of things that, again, that do go against what we understand now from physiological parameters about things that we can do with our hands that we were taught that probably aren't really happening.
Yeah. Actually, there's two things I'm thinking about. One is that is the difference between you when you fall down when you're young and your mum grabs you and you go, oh, I've hurt my knee, and she rubs your knee.
Mm-hmm.
So we know that we're already changing the gait control by changing that. She's unaware of that. And she goes, you're fine, gives you a kiss on the forehead, off you go. Now, is it the rubbing or is it the placebo that your mum's told you you're fine, off you go? And it's, who knows?
Because originally, I think honestly, it's all of it, because it all comes into those things that are really looping into a lot of very powerful, messages that have gotten established in our primate nervous system. But
Yeah.
also, like you said too, there's issues of gait control and neurological facilitation that are happening there too that are changing those kinds of sensations. So what we want to do, I think, as manual therapy practitioners, is find how to tap into that because it's hugely powerful. I mean,
Mhm.
it's probably the most powerful thing that we can do is find a way to tap into that. So that's an exciting piece, I think, for us
Yeah.
for sure.
We had a fellow, Paul Turner, who was an osteopath, who taught. We had components in the second year of the diploma, and when we were teaching it, I was going, "This is the students are not going to get this. This is way too airy fairy." But it was totally on the biopsychosocial area, and he was saying things like, "If there is so much pain, if you can find one spot that there's no pain, and start from there." And then
Yeah.
just say, how does that feel? How does that make you feel? Can we move and go slightly larger and larger and larger area till we can break down the everything's in pain, to change their brain set perceptually that there's an area of pleasant. So,
Yeah.
and that's really hard to teach students who are just all into active, passive, resistive, and then orthopedic assessment.
Yeah.
They don't want to hear woo-woo at that
Right.
stage.
Yeah.
But
And I think one of the other big changes for me too is looking at some, issues related to a lot of things that I had for many years pathologized. Like, you see everybody come in and like, okay, you do your postural evaluation and you look at like, oh, their head, they're looking in front of a grid chart and like, oh, they've got forward head posture, they got a anteriorly rotated pelvis or whatever. And then that becomes a pathology that I need to fix. Um,
mm,
and I think for me now, recognizing a lot of these things too has made me look at that whole process very differently and say, like, there's a lot of reasons that you don't have to do anything about a lot of those things if they're not a problem. And for many people, they're not a
mm.
problem. So we have to be careful that we don't make them into a problem with noceboic language,
Yeah.
what we
Oh my
say.
God, that's terrible. Have you seen your hip?
Yeah.
Or, oh my God, your leg length is half a centimeter
Yeah.
longer on one side. How does your back feel?
These are the tightest traps I've ever seen. How do you live? How do you breathe? Yeah.
Yeah.
Yeah. And, the number of times I've had massage therapists, say that kind of stuff in clinical treatments or whatever, it's like, oh, we got to get away from that, because it
Mm,
does implant ideas in there that not
yeah.
beneficial. Yeah.
Yeah, no. And I noticed there's a couple of comments from Hans. One about, because he's been doing online appointments. He lives in Washington State,
Mhm.
so over your side of the planet.
Yeah.
And postural assessment. I guess you can do postural assessment as a telehealth kind of
Sure. I
work.
mean, yeah, that makes sense. And so to me, the big question becomes from doing that then is how does that impact that individual's day-to-day life experience? Because I'm not on the same boat with everybody that says, every time we see a posture that deviates from the norm, we got to fix it. Nor am I on the boat with the other side that says, don't worry about posture because there's a lot of people that have, forward head posture and no pain. Well, that may be true, but sometimes somebody's forward head posture is part of their pain problem. So that to me actually gets back to emphasizing the whole piece about why assessment is so valuable and needed, because you need to try to determine when is this a factor that's really aggravating the complaint, or when is it something that's probably not so relevant,
Mm,
because there's no hard and fast rules about that. I've really, that's kind of where I've come to with it, is that it does emphasize the need for why assessment is valuable, because that helps us make the decisions about when are some of these things really relevant and when are they less relevant.
yeah, yeah. So
Yeah,
a
not
chronic
gonna say
ongoing
irrelevant,
condition.
but less relevant.
And I think that there's a difference between having a look at a chronicity. So if something's really chronic over a long period of time, then we have to start really keeping an eye and an ear out on common poor patterning and postural issues, versus something that's an acute. They might have just done something random and yeah, they might have tripped and fallen over something, but they just
Yeah,
happen to have a horrible forward head posture
yeah,
that's completely irrelevant to the reason they're seeing you today.
yeah. And, to me, from, getting back to the whole thing about assessment in the world of orthopedics, I still think there's a very important place for a lot of what we had done, or I shouldn't say had, I should have a lot of what we do with orthopedic evaluations, especially for acute injuries, and trying to determine, which tissue is injured and what to do about it. Like, somebody was telling me a story the other day about a client they had that came in that had reached out to a doorknob for, pulling this door, and somebody on the other side of the door grabbed the door and pulled it suddenly in the opposite direction and jerked this person's hand because they were firmly on the doorknob. And then they were getting this, shooting pain sensation down their upper extremity as a result of that. And like, if you understand a little bit about the mechanics of what would likely happen in a situation like that, you can have a pretty good idea. You're probably looking at an acute nerve traction injury. And I still think there's value, for example, in something like that, of just the analysis skills of being able to think about the mechanics of different tissues, what we're exposed to different types of forces under certain kind of circumstances. But that doesn't necessarily translate into the person with, chronic ongoing pain from, sitting in a particular posture at work all day, or whatever kinds of things might be going on in their life that aren't necessarily more mechanically driven. So sometimes it is, and sometimes it isn't. And that's your decision process as the practitioner, is really to determine, what are the key factors here with this individual. And that's the key, this individual person, not just a blanket process.
Yeah. So it's like having two paintbrushes. Your usual paintbrush that you would use under your normal assessment protocol, and then a wider paintbrush that's going to pick up those little nuances and then map them in. So do you then, if we're trying to get people that understand how am I going to apply this in my clinic, would you then start to unpack that more and go, all right, I've worked out that it's, something's going on in the soft tissue, it might be neurological, it might be fascial, and then start asking questions that will get them into the limbic system, get them into an area where we're starting to, how much is pain that's perceptual, how much is pain, and do I need to be treating there, or do I need to be referring them to somebody else psychologically, psychologist, psychiatrist?
Yeah, this is a tricky one for us, because there's a lot of things in there that, maybe if we talk about the biopsychosocial model as an example there, those things that might look like they're starting to live more in one of those other realms that's not the biological or mechanical, where we don't have as much skill set, like in the psychological and social realms. Massage therapists generally aren't taught that much about dealing with those kinds of issues. So those are areas where we don't have as much of a skill set, but also knowing how to work with that, or how to appropriately refer or deal with those kinds of things, can be really challenging as well too. Because I was having a conversation with who was it? I think it was Doug Nelson that I was talking to, who's a practitioner here in the States, really great educator. And we were talking about this whole process, and said like, oh yeah, I have numerous times mangled a treatment session with really badly done pain science education, when you're trying to, like, you learn all this stuff about, the new concepts and theories and ideas of pain science, about, how the brain is interpreting all those things. And then you try to share this with somebody, and you so badly mangle that process. What they come out of there with is, this person's telling me this is all in my head. And this gets back to my thing too. One of my, I said I'm big focus on education all the time. This gets back to a key thing of learning science, and we got to remember this as clinicians, that when we have all of this deep, thorough, comprehensive understanding of the neurobiology of pain, and we get really into this whole process now, the ability to translate that information to somebody who has no background in it whatsoever, the client that comes into you and wants to know why their neck hurts, and you launch into some of these kinds of concepts, you can easily lose them and create a really dysfunctional process, or an unfortunate clinical encounter with them, where they just don't connect with you, and they think you're trying to tell them something like, all this pain is in their head, because you're trying to talk to them about, central processing and all this kind of stuff, and they're just it is right over there. Yeah. So that's an art. That is really an art, is to be able to find how to meet them on that place to share information, but not do it in a point that goes over their head.
Yeah, we had that was the big thing, that we had Lorimer Mosley who talk about the centralization model, and everyone got on board. It was like, oh my God, it's the centralization model. It's got nothing to do with your tissues. Get up and go home. Like, just so somewhere between, we tend to, like you said before, we go on this pendulum,
Yeah.
and we got into that centralization model of it's only in your brain and the tissues are completely healthy and well, versus being smart enough to kind of just go, listen to the pain, listen to the mechanics, have great science. And it's really interesting. Do you think that post now, like you can only fit so much in a diploma, so should we be now adding extracurricular work that's specific for manual therapists that talks on counselling?
That's a good question, because the question, and I don't know that much about the legal scope of practice where you are in Australia, but for us here, that poses another question about where do we begin to infringe on scope of practice for other health professionals. And again, having a background in psychology, I was, as I mentioned, in graduate school studying psychology when I stopped to go to massage school. Um, and I'll be quite honest and tell you that even then, in a graduate psychology program, I was pretty surprised and or uncomfortable with some of the people that I saw that were going into this field to be counselors, because I thought, like, that particular person could really use some skill building processes here. The people that were often drawn into that were some of the people who are, wanting to do work on themselves, which is admirable, but that's not necessarily the way to go about it. So it's tough. It's tricky to find out where those borders are with that kind of thing. But I think it does touch on this issue that as we see some of these kind of models expand, these are areas where continuing professional development courses will be touching for manual therapists and for massage therapists in the future, and they should be, because I think this is getting well past what you can really cram into entry-level education for a lot of folks.
No, we can't. And in Australia, we're not allowed to counsel anyway. Like it's within our health training package scopes that you cannot do. But I think that, as you said earlier, that massage is an arena that can have probably the greatest impact. We should be learning. We should be having like an advanced diploma or a degree in remedial therapy that includes that as part of its outcome, so that we're not breaking over scope of practice of other counsellors.
Yeah,
we're not becoming psychologists or psychiatrists, but we are finding a niche that we can actually assist in that pain science perception.
Yeah. And, this is one of the challenges that I think we, again, I'll speak from the U.S. side of the discussion here of our educational system. One of the biggest challenges that I see us facing here, and we've had a lot of these discussions about whether or not massage should become a 4-year undergraduate baccalaureate degree and that sort of thing. The cost of education in the United States has gotten so exorbitant that it's just really becoming difficult to support a lot of the ideas of making a comprehensive 4-year degree program, and the cost of what that degree program would be and what massage therapists are going to make on the other side of that keep, expanding and growing those kinds of training programs for people who might just want to go out and work in a spa and never have to do any of that kind of stuff. What that really speaks to is the need, and you kind of alluded to this too, that there may be some type of distinguished or tiered credentialing, that is like one level for doing a certain type of more personal care service oriented massage, and another level that's dealing with compromised health conditions or a wide variety of those types of complaints, that people could know that there's a distinction between those two training parameters.
Yeah. And we do actually have some of that in Australia. We've got an exit level of certificate 4, which is kind of more on that wellness day spa, and then up through. And then we're starting to integrate degrees and advanced diplomas, but that's still, the point is that it is expensive. And then you've got therapists who may not be making, like the scope of how much you can charge, depending on whether you're regional, rural, or in the city, is vast. So you don't, you've got people who have got this 4 years of knowledge and can only charge $75.
Yeah. Right.
And then they start going, what's the point?
Yeah.
I mean, they
Yeah.
Hans has brought a good question up, and that was when we're talking about as we're treating how we can actually assess. And he's made that comment about perhaps teaching breath technique and talking whether that changes the pain. What's your thoughts on that?
Yeah, again, I think there's all different kind of ways that we can potentially get into doing those kinds of things, and that's giving us some additional skills and ways to look beyond what we might have ordinarily been doing just with some of our hands-on manual skills. I think there's a lot of, and that incorporates a lot of those things of getting the central nervous system a lot more engaged in what we're doing. There's a lot of fascinating ways that we can use those kinds of interventions to really enhance what we're doing with our hands-on therapy as well.
Yeah. And we talk about exhalation and changing the parasympathetic nervous system and things like that. So we do know that breath makes a difference to the autonomic nervous system. So that in
Yeah,
itself is something.
yeah.
So does doing a deep tissue friction work, or is it nervous system? Like how do we stop people sticking their elbows really, really deep into the gluteals?
Yeah. So again, I think for a lot of us, we have to ask those questions. Why are you doing that, and what is it doing? Because certainly some of the models that we started with when you and I were in school a long time ago taught us some things like deep frictioning techniques with the idea that we're breaking up scar tissue or realigning fibers of torn tendons and things like that. And I mean, I saw people taking those particular techniques and then using them for all kinds of things that they really, in my opinion, shouldn't have been using them for. Like you said, working deeply on, gluteals with a nerve compression problem or something like that with friction in there. And I always was trying to kind of get back to like, why are you doing something like that? What's the intended physiological result? So um, clearly this brings up and poses an interesting question, which is, if things aren't doing what we thought they were doing, what are they doing? Because in many instances, we know people get better, like with, chronic tendon overuse disorders, um, which we were taught a long time ago were the result of tendonitis and torn tendon fibers. And we were realigning those fibers with our friction techniques. And we now know biomechanically that that's probably not likely happening at all, but people still get better when we do that. So what is happening there? And again, this leads us into a lot of the research that's looking into physiological effects of things like, we do know that friction techniques can do certain things like stimulating fibroblast activity that may help enhance some of the healing process. We know that there's interventions that is affecting the central nervous system perception of pain in those tissues and may be encouraging, just a decrease of pain sensation from the intervention itself. And so, the questions really come back to, can we support physiologically a reason why we do those things that we're doing that is supported by current evidence, and know that the evidence pool is really very shallow right now for a lot of that kind of stuff. We have to kind of extrapolate it for certain things and try to figure out how it applies in certain places, because it's not always the same with what we'd love to see, which is a deep pool of good evidence research there that just doesn't exist yet.
Yeah, unfortunately. The I think what this is going to do is it's going to challenge a lot of therapists who did the same technique for whomever comes into their clinic.
Yeah.
So it's that rote learned, this is all I'm going to do, bang, 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 bang. A typical example is I had a gentleman who I did more neuromuscular, like more of an awareness treatment the first time, had some good results, but he's a sports bloke. He wants sports. So I did much more of the conventional no brain, just a deeper work.
Yeah.
Which is against currently what I like to do. And he got off the table and said, I feel that was it. That's exactly what I wanted. And I knew that I was only working here.
Yeah.
There was no way in the world that my tissue work was going to make was going to be any better, probably worse than what I'd done the week before. But I said to him, we'll have a look when I see you the next time. Let's see which one has made the most difference to how you feel, and then we'll have a sit down and a discussion over that.
Yeah. And yeah, what you mentioned there is so crucially important, because I think, we need to make sure that as practitioners, we don't impose our belief systems about what people need on them. If a person comes in and says, this is what I'm feeling like would be beneficial to me, as long as it's not something that I think I'm going to damage somebody doing
Yeah.
something. But, for that particular individual, that's what he felt like he needed. And the client, we know too now, there's a lot of research supporting the idea that client expectations have a really significant impact on outcomes. And so if you come in and expect to get that particular type of treatment and you get your needs met, you're going to feel like you've had a much more successful treatment, even if it's you doing something as a therapist that you think like, I'm not sure this is really going to be the most effective approach in dealing with this person, but that's what they want. That's what their nervous system wants.
Yeah. And there's so many things that we throw out the baby with the bathwater, like that whole concept of the C protein fibers creating pain. I was reading this in that article that actually says that there's no supporting evidence that well, where is it here? It says C-reactive protein in the blood does not predict pain severity.
Yeah.
Which I thought was like, okay.
Yeah.
So it's good that people are starting to talk. So Hans was saying he was holding scar tissue while instructing the body movement that triggered the nervous system to contract against it. So again, we're really working on the brain and its perception.
Yeah.
In order to...
I have this podcast with my partner, Till Lucas, the thinking practitioner, and he said something one day on our podcast that I thought, oh man, I want a bumper sticker of this for massage therapists, saying that oftentimes with what we're doing, the most important tissue that we're working on is the brain. And I think that gets to the heart of it, that a lot of times so many of these things are triggered and governed by the reactions that are happening at the central nervous system level.
I completely agree. And Linda said, unfortunately, not doing anything if it doesn't hurt. So, and that's such a horrible. You're not working hard enough. Can you get right into that? That spot there that it's just a big neuroplexus and great nerve point, and they really want you to get deep into that. Like,
yeah. It's hard because there's a lot of people that just feel like it's not going to work for them unless you get in there with a jackhammer and work super deep and painful for them. There's a lot of people who feel like if something doesn't hurt, it's not therapeutically accomplishing anything for them, and that's an interesting mindset to have to work with, because it's
how do you because Angelica's saying the same thing. Client doesn't want something doesn't mean it's best for them. How do you actually convey that there might be a better treatment option?
Yeah. So, what you can try to do with some people is say, hey, I want to explore some different strategies today with you, because we've been, learning some more about some different ways to address these kind of pain complaints, or what seems to be the challenge here is, and it's a little differently than working with, a lot of deep and significant pressure that we used to do. And I want to see what happens today. So let's, try this as an experiment, see how it works for you. So again, not imposing a model on them per se, like I have to do this or I'm not going to do that for you anymore, but saying, let's take a look at this other option, because I think this also might be really effective.
Yeah. And that's our role, because in that, was it first do no harm? Like if you think about that whole concept of how we should be treating, it's not smart to be aggressive now that we know more about the science of it.
Mm-hmm. And also, I mean, there are some very valid points too about career longevity for the massage therapist, not burning their thumbs and fingers and hands out by trying to use extreme amounts of pressure with individuals, numerous times, for, 6-7 clients a day or something like that. And we see so many occupational injuries happening with people because they're using too much force inappropriately through their hands and fingers. And this, there's a lot of times other ways of working that can still get really good therapeutic results without that kind of overuse susceptibility.
Yeah. It's interesting, isn't it? 3 years, I think, between 18 months and 3 years was a common burnout factor for our industry. Be interesting to see what it's doing now that we're starting to get a clearer understanding of better techniques and approaches. I don't have the stats now.
Yeah. And all kinds of things I think are going to be interesting to see. For example, with the pandemic, what happens on the other side of it, with all kinds of statistics around, who lasted, who hung in there, and stayed in this for a while after it was all over. What kind of schools or institutions are still going to be around when it's all over, not knowing, when that's actually going to be. But I think we're likely to see some pretty significant changes within our field at that time.
Yeah, won't it? Originally, we were supposed to have you and Till on, and funnily enough, Till has too much work on his plate, which is
Right.
standard
Yeah.
for everybody. And we were actually, originally, this was going to be a bit about pain science, but more about how us as therapists manage our own crazy lives, because I think Till had been unwell with a chronic condition, Lyme disease.
Yeah.
And we wanted to unpack to see how therapists, because there's a lot of people here who have been treating for a long time, how do we manage our work-life balance? Because you do 1,000 hours a week. Like, I actually don't know when you sleep, Whitney.
Yeah. Right. Well, I have to be honest and tell you it's not as much as it used to be, because I've been trying to really work on those kinds of things, of having some more significant balance just for the whole mental health aspect of it. I think, it's easy, and you probably recognize this too, because you're kind of in the same boat here. It's easy when you're passionate about something to get too wrapped up in it and feel a degree of, and I see clinicians doing this all the time. I've got to be there for my clients. I got to work on Saturdays. I got to work on weekends. Got to work at night, because that's when my clients want me. And it's great that we have these kind of altruistic ideas for people, but it's easy to get sucked into processes of overburdening yourself and putting too much effort on what you're doing at the expense of your own personal health and well-being. And it's dangerous in the long haul.
Have you got any suggestions on how therapists can reduce the amount of burnout, like notice triggers and like little steps?
The only thing I would say is, like, we do a lot of things coaching our clients about, things to do for their wellness and health that we don't necessarily kind of think about doing for ourselves. And I think it's, for me, just, speaking out of my own personal experience, it's the place where I have had the biggest challenge is, I've always been able to be a survivor of just saying, like, I can take it. Like, I can take the high level stress. I can take the high workload week. I can take the excessive hours. I can take the, trying to respond to everybody at all hours of the day. And that's just, it's not healthy just because you can do that. It's a matter of, really, should you also create a situation, an environment which is much more conducive to a sane type of work activity level, so that you're doing something which you can keep up for the long haul. Because I want to be able to live a comfortable, well life for the long haul and not be overburdened by work and resentful of it either.
Yeah, because we're not looking at our own biopsychosocial. We're not looking at. I always try to encourage therapists. Well, actually, I don't always. I've just started to try to encourage therapists to look at a couple of things. One, try to find something that you're passionate about that's not work related, and factor some time, black out your diary in some spaces where you can actually fall into that and absorb and enjoy it. And two, I was listening to somebody the other day, and I used this term over the weekend. Said, would you, if you were paying yourself, if you were actually being employed by you, would you actually do the hours? Would you actually say, okay, Whitney, I'm now going to make you start at 6 o'clock in the morning, and I'm going to make you work through till about 1:30, and then have a 15-minute quick eat as fast as you can, and then get straight back to work by 1:45. And can you work through to about 6, and then can you do all the washing, and then write up your clinic notes and finish about 9:30, and then can you start again at 6 tomorrow?
Right. That's really true. But, and we fall into some of these things so much because, there are so many practitioners who are solo providers in their own clinic environment and things like that. And you look around and you see, like, if I don't do this, then nobody's going to do it. If I don't take care of the laundry, if I don't take care of the other things, if I don't respond to these, requests for booking appointments, if I don't do this kind of stuff, then nobody else is going to be around here to do it. And it's easy when you own the shop to get sucked into that whole process. And it's a challenging one to be able to set those boundaries and know you got to do things. But that's a great analogy that you gave there about, whether or not you'd really do that or not.
Yeah. When I started to realize that I was treating myself that badly, I suddenly went, "Oh, okay." And I think that the more therapists that realize how we mistreat ourselves, it's insane. There's very few therapists that would say, "No, I'm sorry, I'll respond to you tomorrow. I'll see your email or your text message, but I'll respond to it tomorrow when I have time."
Yeah.
Versus I'm ringing you up at 9:30 at night because I saw your message, and they don't really care. They just go, "Oh, God, my back's a bit sore." I might say, "Oh, I can remember. Oh, I'll send them a text now while I remember."
Right.
And we see that as an urgent call to action.
Yeah. I was listening to this education podcast just a couple of days ago. There's an educational concept or idea called spacing, which has to do with, how people learn, and they actually learn better when they're exposed to something spaced out over time, as opposed to cramming it in a very short period of time. And they were talking about giving feedback to students, and I was thinking about this because I do this all the time. My students, especially in the online program now, they submit assignments, and I feel this necessity to respond to them within 12 to 24 hours to grade their papers and get information back to them. And this podcast, they were talking about research about spacing processes, and found out with giving feedback, they had done these examples with students, and found the students actually got more out of this when there was a greater amount of time of reading the feedback spaced from when they had sent it in. So it actually was beneficial that more time went by as opposed to a shorter period of time, which I thought, like, oh, great.
I'm so happy that you've just told me.
Leeway to not feel so pressured about doing that all the time.
Yeah, fantastic. That's taken the pressure off. Yeah, because we automatically go, "Oh my God, they've sent it." They want to see a response. Like, I've sent it in. What happened? Have I passed?
Yeah. So, but that, that doesn't necessarily mean it gives me leeway to wait till next month to, take a look at it either. So there's a balance in there, of course.
Yeah, exactly. Now, originally when it was supposed to be the three of us, you were saying that you and Till get a lot of comments on your podcast with regards to therapists asking about pain perception. Are there any key questions that they might have asked that we haven't covered here?
I think, those, the things that we've focused on, we did an episode a while back about tissue effects and pain sensations, that, really touching on a lot of these things that you and I were talking about here. That seems to be some of the biggest things. A lot of people are still just kind of getting introduced to some of these newer ideas of pain science. And some of the biggest challenges are that there's, and this happens with all kinds of things, there's a lot of important, really outstanding teachers out there doing a lot of things and exposing people to ideas. But if you don't sort of get some of the bigger picture, it's easy to kind of get dragged down into some of these pieces of these conceptual ideas and not get a whole good understanding of what's really going on there. So with some of these things, and we were also sharing resources of, where can you go to learn more about this, like some blogs and newsletters and things like that, or conferences and things like that are happening where you can learn more about this kind of stuff. There's just tons of YouTube videos out there and things like that are really helpful, articles like the one that Jason wrote that you were mentioning, really, really good piece that he put together there. So yeah, we're beginning to see a lot more resources out there that allow people to have a little bit more balanced understanding of some of these ideas of pain perception, because, you still see a lot of these sort of fundamentalist camps coming against each other with vitriolic responses on, social media threads about stuff. And just some of it just gets, like so out of whack with the concepts and ideas that people are clinging to with, vigor and defense, tremendous defense.
It's almost as bad as the vaxxers versus anti-vaxxers.
Oh yeah,
it's vitriolic. It's so aggressive, and you do see that on the social posts, and people feel that because you're not speaking it verbally, that I can type whatever I damn well want, and you have to hear it.
Yeah, that really becomes a problem. And I've also noticed too with things that I have written, people writing comments back to me about this and saying, "Well, but what about so and so?" And it's like that's not at all what that article said. Recognizing that they caught something or something caught their attention and energy early on in the article, and it basically shielded them from really listening to the rest of the concepts that were discussed throughout there, and they really got just on this bandwagon like I don't believe this or I don't agree with it or whatever, and so and writing in. It's like I really encourage the questioning of those kinds of things, but also read through the whole thing and think about what was really being said there, because it's not actually what the whole gist of the argument was.
And that comes back to the nocebo, the interoception. They've come into, and then they've taken a nocebo effect. So it's a negative response. It hasn't been at the tissue, but it's been at their emotional, how they've actually perceived the balance of your article, and every word they're reading is reading it incorrectly or not as you were designing the article.
Yeah. So, but that's that's going to happen all the time. You just got to be sort of prepared to deal with that kind of stuff anytime you put anything out there. So, but it's necessary, I think, for us to really develop critical thinkers, to encourage people to question things. And there's a lot of, as instructors out there that get really uncomfortable when somebody questions them or questions their model or their idea or things like that, and they become pretty defensive about that. And that's a wholly different problem that we need to try to also nip that in the bud and get away from that, because nobody really likes that whole process of being challenged with their beliefs or their ideas or whatever. But that's how we grow. Also, is to have those kind of those things challenged and creative, constructive criticisms about ideas, so we can break it down and say like, well, is that really true, or is that maybe not so true?
Yeah. Well, we're wrapping up soonish, but I'm coming down to people with PTSD or some of that fright and flight, when you get past that into that fear-based perceptions. And we talk about it a little bit in the courses that I run, is changing the music. Like what are you listening to whilst your client or patient's on the table? What are you burning if you've got an infuser going? How relevant do you think it is that we should be considering their auditory and their olfactory systems when we are treating?
I think it's absolutely essential, because when you try to look at the whole picture, again, the biopsychosocial picture, you're looking at all kinds of sensory inputs, and that's temperature, that's touch, that's sound, that's smell, that's light. That's why we don't do our treatments in a brightly lit fluorescent room most of the time either, because we're trying to create an atmosphere that is most conducive to the greatest sense of relaxation. And that doesn't mean we're going to be able to get it all done. When you talk about the scents and the smell, I was thinking about an incident that I had with a client a number of years back, where I had somebody who came in to my clinic who was a very, very heavy smoker. And the clinic treatment room was relatively small. And so when that person left, the room just reeked of cigarettes. I thought, like, this is not going to work for my next client that's coming in. So I had this little orange flavored or orange scented spray, like a air freshener spray.
Yeah.
So sprayed around in the room, I'd like to try to change the odor in there. And my next client comes in and has chemical sensitivities to air fresheners. How do you win?
Have a cigarette.
That's right. So I was going to lose no matter what I did on that. But those things do make a difference. And, I'm sure she had a less than pleasant experience there because of the air freshener sensation that were in there. It's really hard to know what's going to be just ideal for everybody. But as much as we can tap into the things that are going to be helpful for those individuals, that's really beneficial.
Yeah, Jeffrey says, thank God he's got lighting levels that he can change in the treatment room. And I agree, if you can drop down the light while you're trying to get them into a space of calm, and then when you're trying to do assessment, if you've got dodgy eyes, you might want to have it up a little. Mechanical ventilation, and mechanical ventilation fans to clear stuff out. personally, I've been finding that I've been using Spotify as my background music, and the amount of people who are kind of my age that I put on the playlists that will probably have things like Air Supply and you know Dr. Hook and Dan Fogle. Like, I have a couple of Kinky D. I had someone on my table singing "Don't Go Breaking My Heart" to the music, and she got up and the experience here was so great that the experience of the rest of the body, it was just the most amazing thing. So, sometimes we don't want to always be listening to Enya.
Yeah.
Just saying.
Right. And what you said too is like, it's so hard to know sometimes what is going to do that, because I'm of your pretty similar age group there, and I cannot stand Air Supply. It's like, so if I was hearing that during a massage, I'd be tightening up and tensing up. And then there's that client that comes in and says, "Hey, I brought my own music today. Can I play this?" And you're like, "Sure." And then here comes the Metallica CD or something like that. Like, I've got to work to this, How does somebody relax to that? But, that's their experience, and that's their hour or whatever that they're paying for, So,
and the thing is, don't not let them do it. That's the thing. Allow them the grace. If they want to be playing Metallica or Whitney Houston, it's whoever. The most calming music is Mozart. Okay, I don't mind Pachelbel, but so we've got all sorts of stuff. But it shouldn't be about our music. Is probably my great point. Is it should be about their music.
Yeah, because we never know what it is about a certain song that triggers things for people. Somebody, one person loves Mozart, and another person's parents used to play Mozart all day long in their house when they were growing up, and they can't stand it because they heard it so much, or whatever that is, that's a hard one. But sounds, lights, sense, it all impacts the nervous system, and it's all part of the therapeutic encounter and part of the therapeutic environment there.
Yeah, it's not just touch. We have 5 senses.
Mm-hmm.
So in wrapping, what would be the greatest either tip that you give therapists for the idea about pain perception, pain science, and also the what we'll do is we might get some of the blogs or research, some of the links that you said about some great places to be able to read up more.
Yeah.
So,
so we'll certainly share that. But one thing that I would say for folks is definitely read and learn some things about some of the newer research on concepts of pain science and pain processes in the body, because it does really change the way we look at how we do massage and what we do with massage and what it's capable of doing. And at the same time, don't get caught up in some of the the fundamentalist arguments from those that are really exclusively, saying, pain science is everything and everything else is bunk. Just don't go that far on the pendulum, because what I think it does, these whole the new things that we've learned about pain science opens up a broad group of horizons for us to think about our work in all kinds of new and different ways, and to look at things through different lenses that will make us be even more effective with people than we might have been before. But not if you do those kinds of things in ways that become far too limiting and far too restrictive for you. So it's the Goldilocks process once again, not too hot, not too cold. It's, it's right down the middle.
Yeah. It's never a truer word was said. Try to sit calmly, as opposed to that's my grandma. I don't know if you could hear that. That was my mother's clock telling us it's the hour.
Right. It's the bewitching hour. Okay.
Yes, it is the bewitching hour. I'd love you to come back at some stage. We can talk about something else that is when you find the next new link to massage professionals. If you'd be happy to come back another time, Whitney.
Always love to have conversations with you, Paula. So yes, thank you again very much for the invitation. It's been delightful to hang out here with you for an hour and chat on some of these great topics.
Yeah, it's great. So this would go into the groups that we've got hanging around, so that people can get access to them. I'll make sure that we try to get a few links down for some of the massage magazine is always a good page to look at, and I'll find a few other bits and pieces and put the links to Whitney and Till's The Thinking Practitioner, because that's like, we want to mercilessly plug that because that's amazing. I get a lot of good content listening to those. And if you've got any other questions, please throw them into the chat box later. And if I can get them to Whitney, I will. Thanks everybody for showing up, and take good care. And we will see you on the flip side.
Sounds great. Thanks again, Paula.
Thanks, Whitney.